helpfully, and it seems to me rightly, when he says that health is an objective norm that is the well-working of the organism as a whole. So the health of a squirrel is not measured in its CBC or Chem panel, but it's measured in can it run and chatter and bury nuts and leap from limb to limb. And the same is true for humans. I mean, health is the capacity to live as humans are created to live. But it is to say we're about health, and that we're not. Well-being is a pretty broad term. It can be defined very broadly, and doctors are not, and medicine, it seems to me, are not seeking the fullness. It is not our domain to sort of be, for example, the pastors, to be the financial counselors, to be the ones providing economic sustenance, etc. Now, this universally recognized obligation still provides a powerful criterion by which we can discern that some refusals, however conscientious, are incompatible with good medical practice. For example, the physician who refuses to care for patients with HIV because of an antipathy toward homosexuals, or for black patients because of racial prejudice, or for criminals because of revulsion at their crimes, thereby violates his or her constitutive professional obligations to seek the health of patients because they are sick, without regard to their other characteristics. So the thing that makes a patient my responsibility as a physician, the only thing that makes them my responsibility, and the thing, well, is that their health is either compromised or is threatened. Then they become my responsibility. And without regard to any of their other characteristics, including their finances, but that's another issue. So this obligation, however, to seek health does not provide a criterion by which to condemn the sorts of conscientious refusals that have stirred contemporary controversies. Rather, as biomedical science has expanded, it has made possible many uses of medical technology that are not so obviously directed to preserving and restoring health. Examples include palliative sedation to unconsciousness, so-called, growth hormone for short children, or as we've learned, all of us, for professional athletes, cosmetic surgery, many assisted reproductive technologies, elective abortion, and others. Yet the paradigmatic example of such interventions, and the one that continues to animate disputes about conscientious refusals, is contraception. In 1979, 20 years after the FDA, roughly 20 years after the FDA approved the first oral contraceptive, Mark Siegler and Ann Dudley Goldblatt, two colleagues of mine at the University of Chicago, wrote the following. The oral contraceptive medication was the first prescription drug that was and is, in effect, a self-prescribed treatment. Patients, i.e. medical consumers desiring elective medication, demanded that physicians prescribe the contraceptive pill. Other popularly self-prescribed medications soon followed and came to be seen as appropriate solutions or treatments for problems previously considered individual or social concerns, but in any case not biological abnormalities or specific diseases. Now, neither of my colleagues, I think I can say with some confidence, have any moral qualms about contraception. They're simply highlighting that this is quite different than what doctors had been about to that point. And it's not surprising that physicians become the purveyors of these technologies, because physicians had the scientific expertise and the legal authority to manipulate the body. However, from the beginning, many within the profession have argued that physicians have no business pursuing ends other than health. And despite the widespread use of these technologies, some physicians have always refused to provide them. For a long time, such refusals were uncontroversial. So the medical profession had traditionally given wide latitude to physician discretion in areas of disagreement. Professional codes have consistently stated that physicians are not obligated to satisfy a patient's requests for interventions that the physician does not believe are in the interest of the patient's health. In this respect, and notwithstanding many, many claims to the contrary, physicians who refuse to provide such technologies today are not claiming some new freedom from an old professional obligation. Physician and pharmacist refusals have become newly controversial, I would argue, because the emergence of a new technology, postcoital contraceptives, intensified an old concern about patients having access to reproductive services. For better or worse, as an accident of our political arrangement, physicians and pharmacists have exclusive license to administer technologies by which millions of Americans have come to order their lives. With respect to most of these technologies, if one physician or pharmacist will not provide what a patient seeks, the patient can go to another who will. And the patient incurs relatively modest costs as a result of the clinician's refusal. But postcoital or emergency contraception was and is different. It works, it achieves its intended end, only if administered within a brief window of time. If a woman seeks emergency contraception after intercourse and her physician refuses to provide it or her pharmacist refuses to dispense it, she may become pregnant when she would not have otherwise. Now this has changed somewhat with emergency contraception now being made available behind the counter without a prescription across the United States by the FDA. But there's this concern about conscientious refusal arose when that wasn't the case. And it's sort of spread out to other technologies. In response to reports of such refusals, a chorus of writers argued that doctors and pharmacists must provide or facilitate access to all legal and professionally accepted medical technologies, notwithstanding their moral objections. These arguments lean heavily on a moral distinction and tension between the personal and the professional. I was going to make, I'll put that off for a minute, a comment about the earlier talk today that I thought was very helpful. This tension between the personal and the professional can be posed as personal moral values versus professional ethical obligations, or personal conscience versus professional conscience, or personal versus professional integrity, or personal beliefs versus professional responsibilities. I'm adapting these from different papers that have been published. Unfortunately, this pitting of personal versus professional tends to beg the relevant moral question, because unless and until we can specify our professional obligations, we cannot know whether they are being violated. Nor, and this is really essential, nor can we know which obligations are merely personal. The use of this language of personal versus professional, if you'll pay attention to it, you'll find that personal in this context means nothing other than not professional. And so it's basically just saying professional and other. And so we have to figure out what are our professional obligations. Everything in this debate turns on how we define the substance of our professional obligations, because at the heart of every controversy about physician refusals lies a debate about what medicine is for. As biomedical science generates technologies that people desire to use, questions are raised as to whether those uses are really directed at health, objectively defined. If not, then some argue for a broadening of the concept of health to justify the use of the new technology. Or they argue that physicians are obligated to pursue the new goal in addition to health. In 1982, the President's Commission for the Study of Ethical Problems in Medicine and Biomedical and Behavioral Research, that was the old President's Commission on Bioethics, pointed to the awkwardness introduced by these expansions of medicine's goals. They wrote, "Judgments of conscientious persons have become divergent and perplexed, and societal consensus does not exist. No longer are the proper ends and limits of healthcare commonly understood and broadly accepted. A new concept of healthcare, characterized by changing expectations and uncertain understanding between patient and practitioner, is evolving. The need to find an appropriate balance of the rights and responsibilities of patients and healthcare professionals in this time of change has been called the critical challenge facing medicine in the coming decades." Now, I would argue that if today's controversies are any indication, we are still in those decades. This challenge remains. So those who frame conscientious refusals as a conflict between personal values and professional obligations thereby take one side in a debate they rarely acknowledge. They invoke a conflict between the personal and the professional, or between physicians' interests and patients' health, or physicians' personal beliefs and patients' best interest, without addressing disagreements about whether the intervention in question is really health-related, or even whether the intervention is required to preserve the patient's best interest. Without acknowledging so, these authors exchange physicians' historical commitment to seek patients' objective health for a novel so-called professional commitment to provide, and you'll notice the change in our vocabulary now, what do we provide? Healthcare services, or even in the words of the American College of Obstetrics and Gynecology's Ethics Committee last year, our new obligation is to seek the patient's well-being as the patient perceives it. Think about that for a second. And you could ask yourself what boundaries would be drawn around well-being as the patient perceives it. In so doing, these efforts to rein in conscientious refusals end up promoting a provider-consumer ideal for the doctor-patient relationship that has been widely criticized as being insufficient for and even corrosive of the practice of medicine. Siegler and Goldblatt, my colleagues, drew the connection in 1979, warning that the demanding patient, as they called it, presents a serious danger to clinical medicine. They continued, the demanding patient denies that the physician's responsibilities and expertise have any relevance, except insofar as this coincides with the patient's desires. The demanding patient inverts the traditional model and makes the physician a passive agent. The patient proposes, the physician provides. The physician becomes a technician, practicing under the direction and control of his or her client. End quote. In 1982, the President's Commission published a report called Making Healthcare Decisions, and they echoed this concern. And over the ensuing 3 decades, a series of influential clinicians and ethicists who disagree on a great many other moral questions of substance have agreed that the pendulum has swung too far away from physician paternalism toward an emphasis on patient autonomy that amounts to what the President's Commission called patient sovereignty. In the paternalism model, the physician ordered and the patient obeyed. After the patient's rights movement, the physician proposed, the patient gave consent. In the patient sovereignty model, or what Quill and Brody have called the independent choice model, the patient proposes and the physician provides. The physician has effectively lost both moral agency and responsibility. Arguments for reining in conscientious refusals depend on this latter model being the right one. Only if the physician-patient relationship is one of provider-consumer or technician-client can a patient's long-standing legal right to seek biomedical interventions be transformed into a new professional obligation for physicians to provide what patients seek. Only then can informed consent be transformed into what is now called informed choice. Only then can physicians' obligation to care for the sick be exchanged for an obligation to provide health care services toward the goal of maximizing well-being as the patient perceives it. Some welcome the prospect of physicians answering to their patients regarding what is good for them. After all, if these controversial technologies are not directly related to restoring health, they are at least medical commodities. They are healthcare services, to use the prevalent language, and physicians have no particular expertise or standing to determine whether and how autonomous individuals put non-health related commodities to use. I think that's an important point to be made.